All right, welcome everyone to the Radon Smart Review GYN Cancer Series.
Great to be diving into this.
Today we're tackling cervix cancer part 2. Specifically, mastering those adjuvant decisions for patients who've had surgery, the resected patient.
Yeah, this is such a critical area. You get that post-op consult maybe Friday afternoon.
Exactly. That stack of consults hits your desk, and there it is, the post-radical hysterectomy patient. You got the path report, and you need to decide. Observation, just radiation, or the whole chemo radiation package.
It feels high stakes because, well, it is. But the good news is the data gives us a really clear, evidence-based algorithm.
So our mission today is to build that algorithm, a solid 2-step decision ladder based on the landmark trials so you can confidently manage these cases, distinguishing low, intermediate, and high risk.
Let's really frame that scenario because it's the most common one, the highest yield for learning this. You get the referral, patient had a radical hysterectomy, early stage disease, surgery's done, final path report is sitting right there.
And yeah, the big question hovering over it is always, does this patient need more treatment? And if yes, how much more? Radiation. Chemo, too.
And that's where this 2-step ladder comes in, anchored by two really foundational gynecologic oncology group trials, GOG trials.
Yep.
You have to run this sequentially for every single post-op patient.
Okay, step 1. What's this first question?
Step 1 asks, is the patient low risk or intermediate risk? This tells you if any adjuvant radiation is needed at all.
Right, and this applies if they're node negative, margin negative, parametria negative, correct?
Exactly. If those big 3 Ps we'll talk about are negative, then you turn straight to GOG92. That's the SEDLIS trial.
SEDLIS, okay. And if SEDLIS criteria are met, meaning they are intermediate risk.
Then they warrant adjuvant radiation therapy, just radiation alone.
Okay, that's step 1. Then step 2 is kind of the escalation step.
Precisely. Step 2 asks, is the patient actually high risk? This step is really only triggered by the most concerning pathological features, the big red flags.
And the data for that comes from GOG 109, the Peters trial.
That's the one. Peters tells us if we need to add concurrent chemotherapy to the radiation.
Okay, I like the clarity. SEDLIS first, radiation needed, then Peters. Chemo needed too.
That's the beautiful logic. Intermediate risk gets pelvic RT alone. High risk gets chemo RT. But, before we even jump into the trial results themselves, we absolutely have to be sharp on identifying those critical pathology features.
Yeah, let's nail those down. What exactly are you hunting for on that report? Because these factors map directly onto that 2-step ladder. Right?
They do. So for step 1, the intermediate risk assessment, there are 3 key factors. We use the mnemonic SDL.
SDL. Okay, what does that stand for?
Tumor size. Depth of stromal invasion, is it superficial, mid, or deep third? Yep. And lymphovascular space invasion, or LVSI.
Got it. Size, depth, LVSI. These are sort of the internal tumor characteristics, suggesting how aggressive it is locally.
Mm-hmm. Exactly. But then, separate from those, you have the 3 big pathological red flags. These define the high-risk group. These suggest the disease might already be beyond just the primary site.
And these are the 3 Ps.
The infamous 3 Ps. Positive surgical margins, parametrial involvement, and the big one, positive lymph nodes.
So if you see any one of those 3 Ps...
So you basically skip the whole intermediate risk SDL discussion. The patient is high risk, period. You move straight to the high risk management pathway defined by Peters.
Okay, clear distinction. SDL for intermediate, the 3 Ps for high risk. Now, before we dive into SEDLIS specifically, you mentioned something about histology. Adenocarcinoma.
Yeah, that's an interesting point from the long-term SEDLIS follow-up. While, most cervix cancer is squamous, the analysis suggested that the benefit from adding pelvic RT might have been even more pronounced for patients with adenocarcinoma or adenosquamous types.
So the main criteria, SDL and the 3 Ps, they apply regardless of histology.
Absolutely. But that finding is, well, it's good context. These non-squamous types often have higher local recurrence risks anyway, so it emphasizes that for them, getting that adjuvant pelvic RT, if they meet SEDLIS criteria, is probably especially important. It just adds a layer to the thinking.
Okay, good nuance. Let's unpack step 1 properly then. Defining and treating intermediate risk based on SEDLIS, GOG92.
Right. SEDLIS looked at a very specific group. These were patients who had successful surgery, node negative, margin negative, parametria negative, mostly stage 1B after their radical hysterectomy.
And the trial randomized them between
adjuvant pelvic radiation therapy. The dose was around 46 to 50.4 gray versus just observation. watchful waiting.
So the core question was, even if the surgeon thinks they got it all out, can radiation clean up potential microscopic stuff left behind in the pelvis?
Exactly. Could it reduce recurrences when all those major high-risk factors, the Ps, were absent?
And the answer was,
A clear yes. Adjuvant RT significantly cut the recurrence rate. I mean, dramatically.
Okay.
From 28% in the observation arm down to 15% with radiation.
wow, almost halved it.
Pretty much. And that translated directly to better 2-year recurrence-free survival. It went from 79% up to 88%.
So the radiation was definitely working, controlling disease locally, maybe regionally in the nodes that were left.
It lowered both local and distant failures, actually. Now, here's the key detail you have to grasp.
The overall survival part.
Right. While recurrence-free survival was clearly improved, the overall survival benefit wasn't statistically significant in the trial.
Okay, that's the classic question then. If it doesn't make patients live longer overall in the trial, why do we still do it? Why treat based on SEDLS?
That's the essential point to understand about SEDLS. First, the trial might have been underpowered to see a small OS difference, especially since these patients already had pretty good outcomes after surgery.
Okay, makes sense.
Second, and probably more importantly, many of the patients who recurred in the observation arm were successfully salvaged later on with radiation or chemo-RT.
So the initial treatment didn't show an OS benefit, maybe not because the radiation wasn't effective, but because salvage therapy worked well for those who recurred without initial RT.
Precisely. But think about it from the patient's perspective. Treating upfront with radiation changes a roughly 1 in 4 chance of recurrence down to more like a 1 in 7 chance.
That's a big deal for the patient.
Huge.
Yeah.
You spare them the morbidity, the anxiety, the cost of dealing with a recurrence and going through salvage. So that clear progression-free survival benefit or recurrence-free survival benefit is the mandate here. It's clinically meaningful.
Okay, that clarifies the why. Now, SEDLS gave us the criteria for intermediate risk. We use the SDL heuristic. Size, depth, LVSI. And the rule of thumb is 2 or more factors means radiate. But you hinted it's more complex than just 2 out of 3.
It is. And for resident studying or for discussing complex cases, just saying 2 out of 3 isn't quite enough. It can actually be misleading sometimes.
Why is that?
Because the original matrix from the trial, the one that really defines intermediate risk, is more granular. It recognizes that some factors weigh more heavily than others. LVSI, for instance.
Okay, so let's break down that original granular matrix.
Yeah.
This is key for really understanding it. How do they structure it?
We can think about it based on whether LVSI is present or absent. That's the easiest way.
All right, start with LVSI positive. That seems like the higher risk scenario within the SDL group.
Exactly. If LVSI is positive, the bar for needing radiation gets lower.
Okay.
So number 1, LVSI plus deep third stromal invasion. That alone is enough. Doesn't matter what the tumor size is. Deep invasion plus LVSI equals intermediate risk.
Got it. Deep invasion is bad. LVSI makes it worse.
Right. Number 2, what if it's LVSI positive but only middle third invasion? Then the patient still qualifies, but only if the tumor size is 2 centimeters or larger, greater than or equal to 2 centimeters.
Interesting. So with LVSI, even middle invasion plus just a 2-centimeter tumor triggers RT. That threshold seems pretty low.
It is. It highlights how significant LVSI is considered. Now, compare that to when LVSI is absent.
Okay, no LVSI. Now what?
Now, the size and depth criteria become much tougher to meet.
Makes sense.
So, number 3, if LVSI is absent and the invasion is only superficial third, the tumor has to be huge, greater than or equal to 5 centimeters to qualify.
5 centimeters. Okay, so superficial invasion alone is generally low risk unless the tumor is massive.
Pretty much. And number 4, if LVSI is absent but the patient have middle or deep third invasion,
Yes.
then the tumor size needs to be greater than or equal to 4 centimeters to meet the criteria.
Okay, so comparing LVSI present, middle invasion needs 2 centimeters. LVSI absent, middle or deep invasion needs 4 centimeters. That matrix really shows the weighting.
It does. LVSI is like a surrogate for microscopic spread potential. If you have it, you need less tumor bulk, less size or depth to push you over the edge for treatment.
And if you don't have LVSI, the tumor has to make up for it with more size or deeper invasion to reach that same risk level.
Exactly. And that's why these intermediate risk patients get pelvic RT alone. We're targeting that presumed microscopic regional disease suggested by these SDL factors without needing systemic chemo yet.
That makes perfect sense.
Yeah.
Okay, super clear on step 1 in SEDLS. Let's climb the ladder to step 2, the high-risk patient and the Peters trial, GOG 109.
Right. So Peters focused on the patients who already had clear signs of trouble despite the surgery. They had one or more of those three Ps.
Positive nodes, positive margins, or parametral involvement. The surgical cleanup wasn't quite complete, or the disease was already in the nodes.
Correct. These patients defined as high risk by having at least one P were then randomized to pelvic radiation therapy alone, which was the standard back then for this group, versus the same pelvic RT plus concurrent and adjuvant chemotherapy.
So, adding chemo to the mix. What was the chemo regimen they used in that trial? It sounds like it was pretty intense.
It was. They used a combination. Cisplatin, 70 milligrams per meter squared on day 1, and then a continuous infusion of 5-FU, 5-fluorosil at 1,000 milligrams per meter squared per day for 4 days straight, days 1 through 4.
Wow.
And that whole cycle repeated every 3 weeks for 4 cycles total.
Okay, that's a hefty regimen. Definitely designed for both radiosensitization and hitting potential distant micromets.
That was the idea. And the results, they weren't just positive, they fundamentally changed practice overnight.
How big was the difference?
Huge. Adding the chemo radiation improved the 4-year progression-free survival from 63%, which isn't terrible, but up to 80%.
That's a major jump in PFS.
Yeah.
What about overall survival? Did it show an OS benefit, unlike sedless?
Yes. And that's the crucial difference. Because this was a higher-risk population, the trial was powered sufficiently to show a clear overall survival advantage. OS went from 71% with radiation alone up to 81% with chemoradiation.
A 10% absolute improvement in overall survival.
10%.
That is massive in oncology. That's the kind of number that becomes an immediate standard of care.
Absolutely. It underscores why, if your patient meets any Peters criteria, any of the 3 Ps, the discussion shifts. It has to be chemoradiation because you're fighting for that OS gain.
Did the trial tell us anything else about chemo dosing or cycles?
It did. They found a strong correlation. Patients who actually completed at least 3 cycles of that chemo regimen and who achieved a cumulative cisplatin dose of 210 milligrams per meter squared or more,
Yes.
they had significantly better PFS and OS compared to those who got less chemo.
Okay, 210 milligrams per meter squared. That sounds like a key number to remember, like a minimum effective dose target.
Exactly. It's the threshold linked to getting that survival benefit. It reinforces that dose intensity, getting enough chemo in, really matters in this high-risk setting.
And Peters gave us that crystal clear definition of high risk, the 3 Ps. Let's list them one more time.
Easy to remember. Positive lymph nodes, positive surgical margins, or parametrial involvement.
See, just one of those on the path report.
You stop. You don't need to worry about SDL anymore. The patient is high risk. Chemoradiation is mandatory for the overall survival advantage shown in Peters.
Perfect. Okay, the framework is built. Sedless for intermediate risk, RT alone. Peters for high risk, chemo RT. Let's put it into action with some cases. This is where it really clicks.
Sounds good. Let's start with that setup case we mentioned. 45-year-old woman, post-radical hysterectomy, path shows. Tumor 3.5 centimeters, deep third invasion, positive LVSI. Importantly, nodes negative, margins negative, parametrian negative.
Okay, step 1, sedless check. She has deep third invasion and positive LVSI. Based on that granular matrix, that combination alone is enough, right? Regardless of size.
Correct. Deep invasion plus LVSI positive equals is intermediate risk met. So yes, adjuvant radiation is needed.
Step 2, Peters check. Look for the 3 Ps. Nodes negative, margins negative, parametria negative. So she's not high risk.
Correct.
Final recommendation.
Adjuvant pelvic external beam radiation therapy alone. No chemo. We're treating the intermediate regional risk identified by sedless.
Okay, that's the classic intermediate risk scenario. Now, let's contrast it. Case 2. How Peters overrides sedless. 52-year-old woman. 4.5 centimeter tumor, middle third invasion, LVSI positive. Margins and parametry are negative.
Okay.
But path report says 2 out of 20 pelvic lymph nodes are positive.
Okay, so if we just looked at SDL, she has middle invasion, LVSI positive, and size is 2 centimeters. So she does meet sedless criteria. She's intermediate risk based on SDL alone.
The moment you see positive lymph nodes,
Everything changes. Positive nodes are one of the 3 Ps.
which means
She immediately jumps to the high-risk category defined by Peters. The sedless criteria become irrelevant at that point.
and the rationale is that the OS benefit from chemo-RT in Peters trumps the PFS benefit from RT alone in sedless, because positive nodes signal a higher systemic risk.
Exactly. The finding of positive nodes means radiation alone isn't enough. The required management is concurrent chemoradiation to the pelvis.
Makes sense. High risk supersedes intermediate risk. Okay, case 3, the observation case. 48-year-old. 3-centimeter tumor. Invasion's only superficial, inner 1/3, no LVSI. Nodes, margins, parametria, all negative.
All right. Step 1, sedless check. No LVSI. Only superficial invasion. Size is only 3 centimeters. Does she meet any criteria from the granular matrix?
Let's see. No LVSI and superficial invasion requires size if 5 centimeters. She's only 3 centimeters, so no.
What about no LVSI and middle deep invasion? Needs size equals 4 centimeters. She only has superficial, so no again. She meets 0 sedless criteria, not intermediate risk.
Step 2, Peters check. Any P's, nodes, margins, parametrial, all negative, so 0 P's.
Correct. Conclusion.
Low risk. Management is observation. No adjuvant therapy needed. We avoid treatment toxicity because the risk is low enough.
Perfect. Now one more case. Case 4, to really test that granular sedless understanding. 60-year-old. 4.2 centimeter tumor. Deep stromal invasion, but LVSI is absent. Nodes, margins, parametria negative.
Okay, step 1, sedless, LVSI is negative. She has deep invasion. For LVSI negative with middle or deep invasion, what size did we need?
Greater than or equal to 4 centimeters.
Her tumor is 4.2 centimeters, so it meets the size threshold, equals 4 centimeters, and she has deep invasion. That's 2 factors, even without LVSI.
Exactly. Size equals 4 centimeters plus deep invasion. 2 Sedley's criteria met. She is intermediate risk.
Okay, step 2, Peters. Any P's, nodes, margins, parametria, all negative.
Right. So, final management.
Adjuvant pelvic radiation therapy alone. This case really shows why you can't just rely on the simple SDL 2 out of 3 heuristic. You need to know that granular matrix, especially how size compensates when LVSI is absent.
Beautifully summarized. That's the core logic.
Okay, so once we've used the latter and decided on RT or chemo-RT, we need to actually deliver it safely and effectively. Let's talk technique and counseling.
Right. The standard RT prescription for adjuvant pelvic EBRT, it's still 45 to 50.4 gray, usually in 1.8 gray fractions.
And contouring post-operatively is absolutely key, isn't it? You have to cover that whole surgical bed.
Oh, meticulously. The CTV, the clinical target volume, has to encompass the paravaginal tissues, the parametrial tissues where they were resected, the vaginal cuff, basically the entire area stirred up by surgery.
And the elective nodes.
Definitely. You need to cover the standard pelvic nodal chains, external iliacs, internal iliacs, obturators, common iliacs, and typically the pre-sickle nodes as well. Generally, you treat up to the L4, L5 interspace to cover those common iliacs adequately.
Getting that coverage right is crucial to prevent recurrence in the treated field.
Absolutely. Underdosing the cuff or missing nodal regions is a common pitfall.
Now, technically, how should we deliver this radiation? Any advances there?
Yes, big one. We have level 1 evidence now from the Time C trial, also known as NRGRG 1203.
Right. Time C, what did it show?
It clearly showed that IMRT, intensity-modulated radiation therapy, is preferred over the older 3D conformal technique when you're giving adjuvant pelvic RT.
Why? What's the benefit?
It significantly reduces patient-reported GI toxicity, mainly diarrhea. We're talking about a 40% relative risk reduction in grade 2 or higher GI toxicity. That's a massive improvement in quality of life for the patient.
Especially since they just had major surgery. Less diarrhea sounds like a very good thing.
It really is. So IMRT isn't just fancy, it's the standard of care now for reducing toxicity in this setting. It should be used.
Okay. Now, for the high-risk Peters patients getting chemo, we talked about the original cisplatin 5-FU regimen. Is that still what we use? It sounded pretty toxic.
It was toxic. High rates of mucositis, hand-foot syndrome, fatigue, myelosuppression. It was tough to get patients through all 4 cycles.
And what's the alternative?
Well, contemporary practice and guidelines now strongly favor using single-agent weekly cisplatin instead, typically dosed at 40 milligrams per meter squared, given once a week throughout the radiation course.
40 megs per meter squared weekly. Is that as effective? Was it tested head-to-head against cis-5-FU in the adjuvant setting?
That's the nuance. It wasn't directly tested in Peters. We accept it based on extrapolation, mainly from trials in the definitive chemo-RT setting for locally advanced disease, where weekly cisplatin showed comparable outcomes to multi-agent regimens and was much better tolerated.
So the thinking is, it's probably good enough for sensitization, much easier to tolerate, leading to better compliance.
Exactly. Better compliance means patients are more likely to complete the planned radiation without breaks and hopefully still achieve that target cumulative cisplatin dose we talked about, that 210 milligrams per meter squared. That's still the goal, ideally.
Makes pragmatic sense. So toxicity counseling becomes really important depending on the regimen. For radiation alone,
For RT alone, the main acute things are fatigue, some diarrhea, maybe cystitis. Late effects are key. Chronic bowel or bladder changes are possible, and vaginal stenosis is a big one. You absolutely must counsel on using vaginal dilators regularly, starting shortly after treatment finishes to prevent that.
okay. And if you add chemo, say the weekly cisplatin regimen,
With weekly cisplatin, the big things to warn about and monitor for are nephrotoxicity, kidney damage, ototoxicity, hearing loss, or ringing in the ears and cumulative myelosuppression, meaning dropping blood counts over time.
which means you need to be checking labs frequently.
Every single week before they get their chemo infusion, you need weekly blood counts and chemistries, especially creatinine, to watch kidney function. It's mandatory monitoring.
Got it. Okay, this framework is solidifying nicely. Let's shift gears slightly and do a quick board review section to lock in these key facts. Ready?
Let's do it.
Board review question 1. You have a post-op patient, nodes negative, margins negative. Path shows LVSI positive, stromal invasion is middle third, tumor size is 1.8 centimeters. Does this patient meet SEDLIS criteria for intermediate risk? Yes or no?
Okay. LVSI positive, middle third invasion. What was the size cutoff for that combo in the granular matrix?
It was greater than or equal to 2 centimeters.
And this patient's tumor is 1.8 centimeters, so no, they fall just short.
Correct. Management is observation. You need to know that granular detail. Okay, question 2. 50-year-old post-radical hysterectomy, 3-centimeter tumor, LGSI positive, deep invasion. Clearly meets SEDLIS intermediate risk. However, final path shows microscopic tumor extension into the perimetrium. What is the required management?
Okay, the SEDLIS part is true, but the parametral involvement, that's one of the 3 Ps. Meaning it's high risk according to Peters. Management has to be concurrent chemoradiation to the pelvis. The P overrides the SDL factors.
Excellent. Rationale. Peters criteria for OS benefit. Question 3. Based on the Peters trial, GOG 109, what's that target cumulative cisplatin dose that correlated with significantly better PFS and OS?
That magic number is 210. Greater than or equal to 210 milligrams per meter squared.
Perfect. 210. And last one, question 4. What was the primary benefit seen with adjuvant pelvic RT alone in the SEDLIS trial, GOG 92? Was it progression-free survival, PFS, or overall survival OS?
The primary benefit demonstrated statistically was progression-free survival or reducing recurrences. OS was not statistically different between the arms.
Fantastic. Okay, let's wrap this up by distilling everything into 3 core clinical pearls. What's pearl number 1?
Pearl 1, it's all about the latter. Adjuvant therapy decisions for resected cervical cancer follow that strict sequential 2-step process. First, you assess intermediate risk using SEDLIS. Then you check for high risk using Peters. Always in that order. Pearl 2. SEDLIS defines intermediate risk in node-negative patients. Remember, SDL size, depth, LVSI. Use the granular matrix, but generally 2 factors means the patient warrants adjuvant pelvic RT alone. This improves PFS and cuts recurrences.
And pearl 3?
Pearl 3. Peters defines high risk. Instantly look for the 3 Ps: positive nodes, positive margins, or parametrial involvement. If any one of those is present, the patient is high risk and requires adjuvant chemoradiation. This provides that crucial 10% absolute improvement in overall survival.
Brilliant. So we've really shown today that managing these post-op patients isn't guesswork. It's a logical, step-by-step, evidence-based algorithm. Use SDL and the 3 Ps, follow the ladder, and you can confidently recommend the right path.
Exactly. It takes the mystery out of it.
So that wraps up our deep dive on adjuvant therapy for resected disease. Where are we headed next time?
Next time, we'll tackle the other major scenario: definitive management for locally advanced cervical cancer. We'll dig into the trials like RDOG 9001 and GOG 123 that establish concurrent chemoradiation as the standard in that setting.
Looking forward to it. Now, just a final thought to leave everyone with today. We talked about the 3 Ps, especially positive nodes, driving the high-risk definition. But think about how surgery is changing, with sentinel lymph node mapping becoming more common. it often finds fewer positive nodes than a full dissection might have.
That's true. You might get one positive sentinel node versus maybe 5 positive nodes in a full dissection specimen.
Right. So is it possible that this shift could shrink the high-risk cohort as defined by Peters? And if it does, are we potentially undertreating some patients who are pathologically node negative by sentinel node biopsy, but who might still have significant microscopic disease burden or other high-risk features that our current intermediate risk definition, SEDLIS, doesn't fully capture?
That's a really provocative question. Will we need new trials, maybe incorporating molecular markers or refined imaging, to better define risk in the era of minimally invasive staging?
Something to definitely mull over as practice evolves.
Absolutely. In the meantime, you can solidify today's framework and run through more cases with practice oral boards over at radontSmartLearn.com.
Thanks again for joining us for this deep dive into GYN oncology. We'll catch you next time.